So we kind of left off talking about non-invasive ventilation last time. If you recall, we were talking about, I believe we ended with CPAP and patient interfaces, meaning CPAP prongs. And we went through lots of different types of CPAP prongs and showed how if the CPAP prongs are incorrectly positioned on the patient, that they can cause a lot of complications. So we went through some of those. And again, this talk is about the strategies utilized to prevent BPD. So treatment of BPD, we'll talk a little bit about that today, but that's a whole other topic, which you could speak about for hours or days. So again, when you're listening, just remember we're focusing on prevention of BPD before it occurs. Once BPD is established, then you shift into different treatment strategies. So kind of getting back to where we left off in part one of the talk, CPAP is really one of the mainstays of treatment now in NICUs. We do more non-invasive ventilation than we do invasive ventilation. I still think of non-invasive ventilation as essential to the baby. Unfortunately, a lot of people, once they take the endotracheal tube out and put the baby on nasal CPAP, they tend to relax and think that the baby is better. The reality is that the baby is still getting distending pressure, just like when they were on the ventilator with an endotracheal tube. And most of the time, CPAP is a little bit less secure and stabilized than when you have an endotracheal tube. So in my opinion, babies that are on CPAP actually need as much or more attention than a baby that is on a ventilator with an endotracheal tube, because you can secure the endotracheal tube with a neobar and tape. You can sedate the baby. So there are a lot of things that we can do to try to make babies that are receiving mechanical ventilation with an endotracheal tube safer and more secure in terms of their airway. But the tendency is when people place a child on CPAP who was previously on a ventilator, that they're like, oh, the baby's getting better and now we can relax and not perhaps be as vigilant. And really, I tell everyone that I work with that if you have a patient with nasal CPAP prongs in place, you should treat that patient the same. If the nasal prongs become dislodged or malpositioned, that patient should be thought of exactly the same as a baby who needs an endotracheal tube, whose endotracheal tube becomes malpositioned or inadvertently extubates. So if the prongs are supposed to be in the nose and you find them like this, you should think of that as an inadvertent extubation, because really the baby is losing their distending pressure, and that's similar to what an inadvertent extubation is. So in terms of CPAP, there's been many, many studies looking at the efficacy of CPAP in order to try to prevent BPD. The three main ones have these acronyms. Everyone tries to come up with a fancy acronym for their study. So the COIN trial, the SUPPORT trial, and the Vermont-Oxford Network Delivery Room Management trial. So each of these trials showed a non-significant reduction in the rate of BPD or death at 36 weeks corrected age. So that means they didn't find a difference. There was a trend, but no statistically significant difference. When they pooled all three studies together, there was a small but significant reduction in the combined risk of death or BPD in the CPAP-treated infants. So that means when they took all three studies, put all the babies together, they found a very small, statistically significant advantage for the babies who were treated with CPAP as opposed to being intubated immediately after birth. But the number needed to treat was pretty high, 25 to 30. So the babies do a little bit better if they're on CPAP, but it's subtle. The other thing to keep in mind is that when they pulled all these 3 trials together, 65% of babies who were spontaneously breathing that were extremely preterm required intubation and mechanical ventilation despite CPAP. So in these 3 trials, the researchers were deliberately trying not to intubate the babies if they were spontaneously breathing. So they were trying very hard not to intubate, yet 65% of the babies still required intubation at some point in time. We use a lot of nasal IMV, or nasal intermittent mandatory ventilation. It's also called nasal intermittent positive pressure ventilation. Some people call it cycled CPAP. Those are all essentially synonymous terms. And that mode of non-invasive ventilation delivers ventilated breaths through the nose through nasal prongs. If you compare nasal IMV to mechanical ventilation or CPAP, there's no difference in the outcome of BPD. So if you have a group of babies, you take one and you put them on CPAP, and you take the other one and you put them on nasal IMV, no difference in BPD. So some people would argue, well, why use nasal IMV at all? We should just go straight to CPAP because it doesn't change the outcome in terms of BPD. However, if you have a baby who's mechanically ventilated with a breathing tube and you extubate that child, nasal IMV is more effective than CPAP at reducing BPD and maintaining the baby off the ventilator. Now, a lot of the research protocols use what's called synchronized nasal IPPV, which is not widely or readily available in a clinical setting. So most of the babies that we put on nasal IPPV or nasal IMV have what we call non-synchronized nasal IMV. So what that means is that the machine is just delivering a nasal breath every few seconds. And it doesn't coordinate with the baby's spontaneous breathing. So the reason that's important is that, let's say the baby is exhaling, the machine might be delivering a breath when the baby's exhaling because it's not synchronized. So some people worry about that. There's not a lot of ventilators available that offer synchronization in the clinical setting. And again, the concern is that you could be delivering pressure when the baby's exhaling. Permissive hypercapnia. How many of you have heard of that term? Several of you. So permissive hypercapnia is a strategy that's been used for many, many years in neonatology. It's basically where we deliberately reduce mechanical ventilatory support or mechanical ventilator settings and allow the PCO2 to rise. It's not been found to reduce BPD, but the available evidence that we have suggests that it's safe. So the key there is the available evidence. So sometimes in medicine, we have the evidence that's available, which isn't necessarily the same as perfect or ideal evidence. And so what sometimes we're left to do is take what we have available to us and try to make informed decisions with that. So that's the case with permissive hypercapnia. We have some evidence. It's not perfect evidence, but the evidence that we do have suggests allowing PCO2s to rise is probably safe, but it hasn't been proven to prevent BPD. What permissive hypercapnia allows us to do is to use lower ventilator settings and be a little bit gentler as we help babies breathe. So a couple of caveats about carbon dioxide levels. So carbon dioxide levels have a profound reversible effect on cerebral blood flow. So when your PCO2 is high or you're hypercapnic, there's dilation of the cerebral arteries and arterioles, and that increases your blood flow to your brain. So the concern there is that you could have higher risk potentially for intraventricular hemorrhage. So most neonatologists, most experts feel that high PCO2 values can be dangerous, especially in the first few days after birth. If you recall, most IVH occurs in the first 3 days after birth, probably about 90%. About 99% occurs in the first week after birth. So you'll probably see, and you probably experienced, people not allowing CO2s as high in the first few days after birth in a tiny baby, or the first week after birth in a tiny baby. And as the baby gets older and their risk curve of IVH decreases, usually the PCO2 levels that are accepted are allowed to rise higher. So again, most neonatologists prefer to have a pH of 7.20 or greater. And if you do, and let's say the baby's 3 to 4 weeks old, they may allow PCO2s to rise into the 70s or 80s. Some neonatologists that are on the extreme end of the spectrum, as long as the pH is over 7.20, if the baby has renal compensation and the kidneys are holding on to bicarb, they may let the CO2s rise into the 90s or 100s even. We typically are a little more conservative as a group here at Women's, but you certainly have probably seen 70s and 80s many times on our patients. The other thing to keep in mind is the source of your PCO2. Are you getting your level from an arterial blood gas or a capillary blood gas? So typically, PCO2 on a arterial blood gas will maybe be 10 to 20 points lower than on your capillary blood gas. So sometimes you'll see us with patients who have very high PCO2s on a capillary blood gas. Every once in a while they'll throw out a 90 or 100 and everyone gets anxious, and then we try to get an arterial specimen. Often the arterial specimen will be more reassuring with a much lower PCO2. The other thing to keep in mind is that hypocapnia can also be dangerous. So hypercapnia in the first few days after birth, we like to avoid. Hypocapnia, meaning low PCO2, can also be dangerous. So high CO2 dilates your cerebral vasculature, allowing blood flow to the brain to increase. Low CO2 constricts the cerebral arterioles, decreasing your blood flow. And we know that babies that have prolonged low carbon dioxide levels have an increased risk for periventricular leukomalacia, or PVL. So I consider PCO2 less than 30 as an emergency. So if your CO2 is less than 30 on your blood gas, you should think of that the same way you would think of having a PCO2 of 110. They're both dangerous. The other thing that sometimes you'll experience is, let's say we have a baby who's a 28, 29 weeker who's rapidly weaning on the ventilator, and their CO2s are 28. We wean the ventilator, we get another blood gas, still 28. We keep weaning, we can't get their CO2s above 30. Sometimes we have to extubate those babies. And people are like, oh my gosh, the kid's 600 grams and we're having to extubate. Well, we're trying to protect their brain. So some of you may have experienced that as well. This slide gets back to the fact that with the CPAP trials where they were deliberately trying to avoid intubation, many of those kids end up intubated at some point in the first week of life, regardless. So this was a study done by Neil Feiner, where he was looking at babies less than 28 weeks of gestation, deliberately trying not to intubate them with an endotracheal tube. And you can see that many of the babies still ended up getting intubated at some point during the first week of life, especially the tinier kids. So almost all the 23-weekers, half of the 24 and 25-weekers. And as you got older, you were less likely to have to be intubated at some point in the first week of life. The point is here that even with our best intentions, many of these kids are going to still end up intubated for a while, but that's okay. In general, I think most people believe that any time without an endotracheal tube in place is good, even if it's just a few hours or several hours. So ventilation strategies for the prevention of BPD, non-invasive ventilation. We try to be conservative when initiating ventilation, meaning let the baby work, let their FiO2 increase, maybe their PCO2 increase, and if they don't get better, you're trying to manage them non-invasively. At some point, you may have to intubate them. But once you intubate them, we try to be aggressive getting them off of the ventilator. So conservative putting them on, aggressive getting them off. Permissive hypercapnia, we use that both to initiate and maintain mechanical ventilation. What does that mean? That means that we might let the CO2 get fairly high before we go ahead and put the baby on the ventilator. So that's using permissive hypercapnia in terms of initiating ventilation. Once the baby's on the ventilator, we use permissive hypercapnia to try to avoid turning the ventilator support up. Some people use the term gentilation. You may have seen that. It's in the medical literature, or gentle mechanical ventilation. What this typically means in tiny premature babies is to use a high rate, low tidal volume strategy. So what's a high rate? 40 to 60 breaths per minute, and a low tidal volume, 4 to 6 milliliters per kilogram. We typically use short inspiratory times, typically about 0.3 seconds, and we want to make sure we use adequate PEEP. We also try to minimize the FiO2. Sorry, I'm getting texted here. We try to minimize FiO2, allow permissive hypercapnia, and we want babies in general to breathe spontaneously. So most of the time in the NICU, we don't heavily sedate our patients that are on mechanical ventilation. We try to lightly sedate them. Again, our goal is for the baby to breathe spontaneously and ultimately get them off the ventilator. We use pressure support to decrease the work of breathing. Tiny babies often don't generate great tidal volumes on their own, and that increases the dead space to tidal volume ratio. Do you guys remember in the first half of the talk when we talked about dead space and various types of dead space? So dead space is space within the air tree that isn't participating in gas exchange. So that can be the endotracheal tube, the tubing of the ventilator circuit, but it can also be areas within your lung tree that don't have alveoli. So your main bronchi, those are just tubes that the air is going through. There's no exchange of carbon dioxide and oxygen in your main stem bronchi. So that's technically dead space. So we want to minimize dead space. As we wean the ventilator, if we don't give the babies any pressure support, then we're really potentially increasing their work of breathing. So when you get down to rates of 15 or 20 breaths per minute in a tiny baby, a 27-weeker, if they don't have any pressure support, that actually might make them work harder than when they're on a rate of 30 or 40. So we do have to give them some pressure support. The main thing pressure support does, we know from adults, is that helps overcome the resistance of the breathing tube. Do you guys remember we also talked about resistance in the breathing tube and how the length of the tube and the diameter of the tube affects your resistance? Is this loosely familiar? So the pressure support helps overcome the resistance of the breathing tube and make breathing more comfortable. When we use high descending pressures or high descending pressures like PIPs, let's say of 25, 26, 27 in a baby that weighs 700 grams. So if we get to that point and ventilating a tiny, extremely low birth weight baby, then we typically think about switching over to high frequency ventilation. What about suctioning? A lot of you probably know more about suctioning tiny babies than I do, because I don't do it. You guys do it. But what the experts say is that routine scheduled suctioning leads to derecruitment of the alveoli, transient hypoxemia, and also perturbs cerebral blood flow. So you guys have probably seen kids that we suction and they don't like it and they desat, and it takes a while for them to recover. So what the textbooks recommend is that you suction when you hear fluid in the tube or see fluid in the tube, you're hearing or seeing secretions, if you see abnormal waveforms on your ventilator flow loops, and when you do suction, try to be gentle and quick. Volume-targeted ventilation. So many of you will probably hear about volume-targeted ventilation, and some neonatologists have really adopted this as the main way they mechanically ventilate babies. The reason why is that when you use volume-targeted ventilation, you control the volume that you're delivering the baby, and you let the pressures vary. The reason that people have adopted that mode of ventilation is, of all the different types of trauma you can impose on the lung, volume trauma is felt to be the worst. So with volume-targeted ventilation, we're controlling the volume, hopefully minimizing volume trauma. So the volume applied to each breath is limited, and what volume-targeted ventilation allows you to do is, as the patient's lung compliance changes, the ventilator will just automatically adapt as their lung compliance changes. And that's important for babies with RDS because their lung compliance changes rapidly, especially when we deliver surfactant. So again, back to our first half of the talk. Do you guys remember the compliance pictures? So change in volume over change in pressure. And we had a line like this, kind of, that was a normal lung, and then a slope that was much lower for the compliance of a baby with RDS. So if you have low compliance, you give surfactant, within minutes, your compliance can change, and the baby can start having really big breaths. And so if you're on a volume controlled ventilation or volume targeted ventilation, the ventilator is going to quickly decrease the volume that it's delivering to the baby as the compliance changes. And that helps protect the lung. So when it's been studied, there's some small studies that suggest volume-targeted ventilation is better than pressure ventilation, but there's no definite study showing it's superior. So this gets into kind of the art of medicine and the interpretation of medicine. Some people really feel that we should use more volume ventilation because they feel it's safer, and they feel like when they read the studies, it's more definitive. My take is there may be some benefit, but it's not definitively proven. And the other thing I would say is, you've probably heard me say this before, the most important thing is that whatever mode you use it well and with skill. Just like with whatever ventilator you choose to use, you use it efficiently and with skill. So I would say it's not the tool, it's the carpenter. I don't know if I put up that quote for you in the last talk. So it's the carpenter, how the carpenter uses the tool, not the tool itself. That's my philosophy.
So are home vents for these kind of kids more likely to be the volume-targeted ones because of who they are?
Well, remember, we're still talking about prevention of BPD. So if you're going home on a vent, you have BPD, and at that point, the ventilation strategies are likely different than what we do in the first few weeks of life for for a very low birth weight baby. The other thing to keep in mind is if you're going home on a ventilator, that means you have severe BPD. Of all babies with BPD, only about 1 to 2% of them are so sick that they would have to go home on a ventilator. So you're talking about all very low birth weight babies with BPD. And then the next level is BPD so severe that you need mechanical ventilation. So that's a very small number, and their lung strategies are much different. High-frequency oscillatory ventilation. This could be a whole talk in and of itself, but I've tried to condense it down to one sentence. High-frequency oscillatory ventilation does not decrease the rate of BPD compared to regular conventional mechanical ventilation. This was highly studied in the early 2000s, and really there appears to be no difference in the two. So if you take tiny babies and you put them on one mode or the other, the rates of BPD are essentially the same. And I'll leave it at that. So these are some of the things that we've talked about so far, strategies to prevent BPD. Most of this was in the first half. We talked about preventing prematurity. We talked about antenatal steroids and surfactants. I just went over some gentle mechanical ventilation strategies. We talked about minimizing oxygen toxicity, non-invasive ventilation, permissive hypercapnia, volume-targeted ventilation. So next we're going to move quickly through some of these other strategies that we use, including use of systemic steroids and antibiotics, optimizing nutrition, which is just going to be a couple slides because that could be a whole talk, caffeine, vitamin A, and then a few others. So postnatal steroids. We have to think, again, there's postnatal steroids to try to prevent BPD. There's postnatal steroids that we give to treat BPD. Dexamethasone suppresses cortisol production, and it only binds to glucocorticoid receptors. The other thing about dexamethasone is it promotes apoptosis. Apoptosis is programmed cell death. So one of the theories why high dose, long durations of dexamethasone can lead to cerebral palsy is because dexamethasone can basically induce apoptosis. Hydrocortisone, on the other hand, is identical to cortisol. It binds both mineralocorticoid and glucocorticoid receptors. When you give steroids, you have to be aware there are lots of potential side effects. And this is not an exhausted, comprehensive list. These are just some key ones I thought of. So you can have spontaneous gastrointestinal perforation, especially if you give steroids in conjunction or combination with endomethacin. Hypertension, we've probably all seen that. In fact, sometimes we use systemic steroids to treat hypotension, right? Hypertrophic cardiomyopathy, infection is a big one. So our patients are already immunosuppressed. We give them steroids, make them even higher risk for steroids. Hyperglycemia, again, sometimes we use steroids to treat hypoglycemia. Reduce weight gain, you've probably all experienced that where we're trying to get a tiny baby to grow and they don't grow so well, especially if they've been on multiple courses of steroids. And then with dexamethasone, the big concern is with the potential development of cerebral palsy. Now, it's important to know that most of the studies that looked at weaning babies from ventilators by giving them dexamethasone were done in the 90s and early 2000s. And when they used to give dexamethasone back then, they gave it for 42 days in a row. And they gave very high doses. And the dexamethasone worked. It helped babies get off the ventilator. What we learned was that those babies were at subsequent risk for the development of cerebral palsy. And because of all of those babies that got those long courses of dexamethasone, the way we give, and some of which develop cerebral palsy, the way we give dexamethasone now is much different. So what we do now, and again, this is, we're still in the prevention of BPD phase here. In the first postnatal week of life, so 0 to 7 days of age is your first week of life. In terms of dexamethasone, we know that it reduces BPD, but it increases your risk of cerebral palsy. So we don't give it, if at all possible, during the first week of life. Now, you may have seen that a baby get it in the first week of life, and that's probably because that we thought that baby may die, and we're just trying everything we can to keep the baby alive. Hydrocortisone has been studied, and if it's given at a low dose in the first 10 days of life, it reduces BPD. The problem is it's associated with an almost 2 times risk of late onset sepsis in the tiniest babies, 24 and 25 weekers. So the kids that you most want to help, you're putting at the highest risk of infection if you give hydrocortisone. There's also the concern I mentioned, if you give steroids with endomethacin, you can have an increased risk for GI perforation. So what happens a lot, you guys probably haven't experienced it as much in the last 5 years, but 10, 15 years ago, many of the tiniest babies that we took care of, the 23, 24, 25 weekers, many of them were hypotensive and ended up on dopamine and dobutamine and often hydrocortisone. And then we got an echo, and they had a patent ductus arteriosus, so we gave endomethacin to try to close their ductus, and they developed a GI perforation. So we tried to avoid the combination of steroids, which is usually hydrocortisone if we're giving steroids for low blood pressure, and endomethacin. Now, we don't see that situation as much anymore, and my theory is that we're doing so much more non-invasive mechanical ventilation, we're getting babies off the ventilator sooner, their intrathoracic pressure is not as high, and so I think their blood pressure is better. Just a thought. After the first week of life, so postnatal week 2 is days 7 to 14, we can give dexamethasone if you're still on the ventilator, but you have to be aware of the risk-benefit trade-off. The most common protocol used is a DART protocol. So somewhere between 1 week and 3 to 4 weeks of age is probably the most common time that we should be using the DART protocol. We often use it later than that, but when it was studied, it was looked at babies in that age group. Now, if you get into the 4th, 5th, 6th weeks of postnatal life, then you're really entering in treatment of BPD type territory. And again, we don't have enough time to talk about that, unless you guys want to stay here for another 4 hours. Yeah.
We've also been giving babies prednisolone. What's the difference?
So prednisolone, different steroid with different potency. That's, again, into the treatment. So I won't say never, but close to never should you see a baby less than 3 or 4 weeks old getting prednisolone. A premature baby, yeah.
What about giving steroids prenatally?
So we talked about it in the first half of the talk. When was that? October. So yeah, we do give steroids prenatally, but that has not been shown to reduce the risk of BPD. What giving steroids prenatally has been proven to do is reduce the risk of RDS, necrotizing enterocolitis, IVH, and death. So lots of good things, but not any effect on BPD. So again, just kind of summarizing the last slide, how do we use systemic steroids in 2018 to prevent BPD? We generally don't use in the first week of life. The American Academy of Pediatrics advises against using steroids at that time. And then if you have a baby who's still on the ventilator with lots of ventilator support, high oxygen need, then we have to look at those babies and say, are they at high risk for going on to develop BPD? And then you have to look at the risk-benefit ratio and potentially start them on the DART protocol. So again, high ventilator support, high FiO2, perhaps a deteriorating status, and say, is this baby look like it's at high risk for developing BPD? And in those cases, we may give steroids. You do need to have a discussion with the parents and document it in the medical record. And for me, that 1 or 2 sentences is fine. I discussed this with the parents. I told them the risks. I usually try to remember to write the risk of cerebral palsy because that's the big one. But 1 or 2 sentences is fine from my perspective. So nutrition, the key thing here is that breast milk is associated with less necrotizing enterocolitis and ROP, but we don't have any trials showing that breast milk prevents BPD. We do have to optimize nutrition once a baby has established BPD, or even really before that. You have to develop new lung tissue for your lungs to improve. So when we have babies that don't grow well, we worry about their brains and also all of their organs really, but also their lungs. So when you have a baby with severe BPD, we really try to optimize nutrition, which is sometimes very difficult, right? Because they are on steroids and they're on diuretics, and maybe they get infections intermittently and have to be NPL. So it can be very challenging to get those babies to grow, even though they're the ones who most need optimal nutrition. Caffeine has been shown to reduce BPD. It's most effective if you start it early after birth. Vitamin A. How many of you have even used vitamin A ever? So when I was a resident and a fellow, even when I first came to Omaha, we used vitamin A on all babies less than 1,500 grams. And the reason why is that it was one of the few things that was well studied and proven to reduce BPD. The bad news is when kids that received vitamin A were followed up at 18 to 22 months, the long-term benefits in pulmonary and neurodevelopmental outcomes were no longer seen. The other bad thing about vitamin A is you have to give it intramuscularly. And it was usually given Monday, Wednesday, Friday for 4 weeks. So that's 12 IM injections in tiny babies. So that gave a lot of people angst, like nurses who had to give the injections. So it's expensive. So it's expensive and it's painful, and they're little babies. And it's hard to look forward years ahead of time and go, oh, I'm helping their lungs, right? It's just hard to do. And the number needed to treat was about 14 to 15 babies. So you're giving a lot of injections with an expensive medication for a number needed to treat that's arguably a little bit high. Vitamin A has been on a national shortage since 2010. So I haven't been able to give it to any patients for almost 9 years now. So that's probably why many of you have never given it, because lots of places around the country don't have it anymore, or don't have access to it anymore. The interesting thing is that since vitamin A use has decreased due to the national shortage, we have not seen a corresponding rise in BPD. So anyways, mainly since of the national shortage, vitamin A is just kind of not used very much. But it is one of the therapies that's been studied well and proven to decrease BPD. So just keep that in mind when we're using things that maybe aren't as well studied. Inhaled nitric oxide. This is highly controversial. It's been extensively studied for, probably 20 years now. The National Institute of Health does not support the use of INO in the care of infants less than 34 weeks. So how many of you have given nitric oxide to a baby less than 34 weeks? Yeah. And you're doing that because, it was ordered. But just be aware, some places, many places around the country don't do that at all and would frown upon me for doing so. If you look at Vermont-Oxford network data, people all over the world are giving it to tiny babies. So even though it's not approved and often not reimbursed, so when we give this to tiny babies, a lot of times insurance won't pay for it and the hospital has to eat the cost and it's expensive. Just keep in mind that we're not the only ones. And we know that because when you look again at Vermont-Oxford data, which are NICUs from all over the planet, everyone does it. Now, does everyone do it to the degree we do? I don't know. I think it varies from unit to unit. But many neonatologists still give it. Just remember that when we do that, it's what we would call off-label, okay? And it's not approved technically by the NIH. Infections, again, early onset sepsis and late onset sepsis are talks in and of themselves, but just know that when these preemies get infected, it increases their risk of BPD. So nosocomial infections increase your risk for BPD. So that's one of the reasons why we try to prevent these kids from getting bloodstream infections or meningitis. So which strategies are proven? I think I tried to highlight the ones in blue. Prevention of prematurity. Lots of these are good things that we think are helpful. Non-invasive ventilation, systemic steroids, caffeine, vitamin A. So the other things that we've talked about, many of which we do all the time, not definitively proven to reduce the risk of or prevent BPD. So surfactant, general mechanical ventilation, the permissive hypercapnia, volume-targeted ventilation, all of these things, some of which people very strongly advocate. Many of them not definitively proven. If you can prevent prematurity, that's good. Try to get the baby off the ventilator and use caregivers that learn the patients, because you're right, keeping them comfortable is a big part of it. And you don't want to use drugs if you don't have to keep these kids happy. But you've all seen it, like a kid who's having a restless stay and his FiO2 is up 10 to 15%, and then I see it all the time, and then a different nurse comes on at shift change who maybe knows the baby better or has some nuance in her head that this is what he needs or she needs, and they do something and the baby's FiO2 is down by 15 to 20%, the kid's breathing more comfortably, and we didn't give a drug, and I'm like, what happened? Oh, well, I don't know, I just did this. And you're like, okay, well, we should always do that. But then the nurse goes off shift and and it doesn't happen. I don't know how to fix those things, but how it is that a nurse knows to do those little things is amazing to me, because I don't know how to do that stuff. Other thoughts? Were these two talks helpful? Okay, I don't have anything else to say. So next question is, okay, so what do we do? We've talked about a lot of stuff over the first half and the second half. what do we do starting in the delivery room? So we try to stabilize a CPAP if the baby's spontaneously breathing and reserve invasive mechanical ventilation for infants who fail non-invasive respiratory support, or if they're really tiny, in some cases we may just intubate those babies. So we're talking about the 23-weekers, 24-weekers, because remember I showed you several slides back that even in studies where people tried to avoid intubating, the 23-weekers, almost 100% of them got intubated. So if you're in the delivery room with many neonatologists and the baby's really small, 23, 24, 25-weeker, 500 grams or less, or maybe 600 grams or less, those babies are probably going to end up intubated. So if you intubate the baby and put them on mechanical ventilation, you want to give them surfactant early. What's early mean? Within the first 2 hours of life. Many of those kids are going to get surfactant in the delivery room. You also have to try to minimize their oxygen toxicity. So that means you need to titrate your oxygen starting in the delivery room. Use the NRP table. In our delivery room, the table is posted. This is what it looks like. So the baby's oxygen saturations vary depending on their age and minutes. So you want to keep their oxygen saturation targets appropriate for their age and minutes, and you don't want them to be too high. The current recommendation from NRP is to start preterm babies between 21 and 30% FiO2 in the delivery room. And also remember that it takes several minutes to reach 90% oxygen saturation. So this is hard even for me, okay, because even I want those saturations to be good, especially if the heart rate's borderline. Then everyone starts getting a little anxious in the delivery room. So you may have to help me sometimes. Say, Brady, it's okay, heart rate's good, just be patient, don't start cranking up the FiO2. So, but that is hard to do when you're in the delivery room, but try your best to avoid the temptation. So a little bit more specific. So if you're less than 25 weeks, you're probably going to end up intubating those babies and giving them surfactant. So you're really talking about the 23 and 24 weekers if you're less than 25 weeks. 25 to 28 weeks, what I would recommend is trying to do nasal IPVV or nasal CPAP if you're able, which is a better alternative. This is mainly from the first half of the talk, a better alternative than intubating and placing the baby on mechanical ventilation. If you're intubated, give surfactant. Sometimes we do that via the Ensure method. We talked about the Ensure method in the first half, intubate, surfactant, extubation. If you leave the baby on the ventilator, wean rapidly with a goal of getting them off the ventilator by the first 2 hours of life. And then when you extubate the baby, just remember there's less extubation failure if you use nasal IPPV as opposed to CPAP. If you're greater than 28 weeks of age, you should really try to manage these babies without intubation. So manage them non-invasively. That being said, if the baby's creeping up on their FiO2, their x-ray looks really like severe RDS, a lot of those babies we're going to insure. And I think many of you have probably experienced that. A lot of those kids get insured. Remember, for small babies in the delivery room, we started our recruitment of their FRC with the first breaths of life. So, you know, the minute we put the face mask on, we have a PEEP set at 5. So we're immediately starting lung recruitment. So surfactant, we want to administer early, then extubate to nasal IPVV, which is better than nasal CPAP. Goal is to get them extubated without an endotracheal tube by 2 hours of life. This is an important one that I hear from nursing staff all the time and drives me insane. Sometimes I don't tell you it drives me insane, but it drives me insane. Fear of future reintubation should not be a reason to delay an extubation attempt. Okay? Absolutely shouldn't. I showed you a graph, or actually two graphs in the first half of the talk that sort of proved why. Remember, the tiny babies had, I think, a 60%, so better than half, chance of remaining extubated for greater than 7 days. You guys remember those slides? If not, you can go back and look. But it sort of proves that it's a myth that tiny babies can't stay off the ventilator. I'm saying that because that's what the data suggests. The data suggests that small babies can and will stay extubated more than half of the time. So when you don't give a baby that deserves a shot, you could be doing them harm. When we extubate, we typically use short binasal CPAP prongs, and you may go, what are you talking about? So people have actually studied looking at single nasal CPAP prongs or deep prongs as opposed to short prongs. The RTs are probably more familiar with this, but we typically use short binasal prongs. So many of you don't know any different because that's all we use. You also want to use an oral gastric tube to decompress the stomach. And I typically adjust nasal light PPD settings the same as I would for a baby on invasive ventilation. You say, okay, what does that mean? I need some numbers, Brady. You can't just say adjust the nasal light PPD like you would a baby on a ventilator. So I kind of broke this down into what I call primary mode, or a sicker kid, versus secondary mode, or a less sick kid. So when I say primary mode, that's a baby that either has never been intubated with an endotracheal tube and on a ventilator, but who's pretty sick and you're trying to keep him off. Or if you extubate a child who's got pretty sick lungs and you're not so sure if they're going to fly off the ventilator, for those kids I'll use a rate of 30 to 40. And their PIP, typically about 4 higher than their PIP was on the mechanical ventilation. PEEP, I'll probably use 6, 7, or 8, so a higher PEEP, and a night time of 0.5 seconds. Sometimes in these kids I'll go up to a night time of 1 second. I usually try to make sure they're on caffeine, which they almost always are, and try to keep their hematocrit about 35% or higher. So a baby that's been ventilated or who's not as sick, I'm not as worried about extubating them. I think they're probably going to be okay. I'll probably start with a nasal IMV rate of 10 to 25, a PIP of maybe 2 to 4 higher than what their PIP was on the mechanical ventilator. PEEP's probably going to be 4, 5, or 6, and a nighttime of 0.5. Again, caffeine and a hematocrit that's reasonable. So what about transitioning from nasal IMV to a CPAP or a low-flow nasal cannula? Now remember, from the first half of the talk, we went over many reasons why we don't typically use a high-flow nasal cannula, or at least I don't advocate for a high-flow nasal cannula, so I didn't even put this in here. So I just eliminated that as an option. Because if you're hanging out with me, I'm going to tell you I wouldn't do it. So going from nasal IMV to CPAP, I usually get the baby's nasal IMV rate down to 10 or 15 before I say, okay, just go straight to CPAP. PIP, 14 to 15, and then a PEEP of 4 or 5, sometimes 6. FiO2 would be ideally less than 30% and having reasonable blood gases. So basically, the other thing you can do is just, they're on nasal IMV, they're at all of those settings, and you just turn the rate to 0, and you basically switch them to CPAP. What about going from nasal CPAP to a low flow? So typically, I would prefer those kids be on a PEEP of 4 or 5 with an FiO2 less than 30%. Now, do we always achieve that? Not necessarily. So sometimes, if we're patient and the kid still isn't weaning, we're we've got them on diuretics, we're being patient, it's been a few weeks. Sometimes we just go, okay, we got to try them on low flow. So, but ideally, PEEP of 4 or 5 and an FiO2 of less than 30. So if you are to use high flow nasal cannula, just remember to use heated, humidified high flow nasal cannula, or what people will sometimes call the triple H.
Great.
Yeah.
Why do you not use one?
So we went over this in the first talk. There's two major reasons. Number one, you don't know how much descending pressure you're giving to a baby when you give high flow nasal cannula. Or maybe there's only one reason. That's probably the main reason. You can't measure it. You can't measure what you're delivering. So you could be delivering 2 centimeters of water pressure, or you could be delivering 10 centimeters of water pressure. But you have no idea because you can't measure it. And the delivered pressure varies, whether the baby's mouth is open, how tight the nasal CPAP prongs are in the nose, and with the baby's weight. So there's a lot of variables, and you can't measure it. And so I showed in the first half of the talks some examples of kids that were on a high flow nasal cannula who got descending pressures that were much, much higher than intended, and they had air track. We had one that I showed into the scalp, one into the orbits, so pneumocephalus. So we don't see that a lot, luckily. High flow, heated, humidified high flow nasal cannula is probably much safer in babies that are larger because the estimated descending pressure depends on the baby's body weight. So in tiny babies, I think you have to be really careful with it. And since we have such a good patient interface now with the RAM cannula, to me that's almost eliminated the need for our high flow nasal cannula. So 10 years ago, before the RAM cannula, there was a big push to get the babies to high flow because the patient interface, it was just so much comfortable for the baby. And the CPAP prongs were not so nice, you know, and people are like, oh, we just got to get them off CPAP because of all those, you know, different nasal anomalies I showed you. But once the RAM cannula came out, we had a way to keep the baby pretty comfortable because it's very similar to a high flow patient interface, but we can measure the descending pressure. So that's really, I guess, my main reason for not using it. I had another one in my mind, but it's escaping me at the moment. Some newer therapies to talk about. Sustained lung inflation and less invasive surfactant administration, or sometimes called LISA or LISA. Mostly LISA, I believe, is how people are saying it. There's also something that many of you have probably heard about called NAVA, or neurally adjusted ventilatory assistance. So that's when the ventilator breaths are triggered by the electrical activity of the diaphragm. And then there's also nasal high-frequency ventilation, which is not commonly used, but basically imagine using the oscillator through the nose. So sustained lung inflation is a lung recruitment strategy that starts in the delivery room with the first breath. And basically what you do, instead of putting the face mask on and just delivering CPAP that the baby would breathe over, that level of CPAP, and we talked about that as well in the first talk. What you do is you basically give a positive pressure breath and you hold it at that peak PIP. So, and you hold it for several seconds. So for example, you put the face mask on, you might give a breath of 20 centimeters of water pressure, and you just hold it there for 20 seconds. And it's almost like you're giving a CPAP of 20. But you hold that sustained inflation for several seconds. And that's supposed to help recruit FRC and clear out lung fluid. So there's been a lot of trials that are ongoing, and to date, I don't know of any benefit, but you're probably going to hear about that. Some places are doing this already, so you may see that in some delivery rooms. Some very well-respected places are doing this. What is less invasive surfactant administration? This is where people are taking basically a feeding tube, and they're putting it into the trachea and instilling the surfactant through the little feeding tube. This has actually been shown to reduce BPD, and it's pretty well studied. It's much better studied than some of the methods that we already talked about for reducing BPD, and it's becoming more widely used. At some point, we might start doing this. We're not doing it yet, but it might be in the future.
Within the skin that you're keeping the airway open, is that why they think that it's better for the baby?
Yeah, I think it's felt to be less traumatic than putting the breathing tube in. I'm not 100% positive as to why that makes it more efficacious, but I think that's the theory. Yeah, Victoria.
Do you still have to visualize the...
Yeah, I mean, you got to make sure you're not putting in the esophagus.
So you would still use a blade?
I believe they're using a blade, and I don't know if they're taking like alligator forceps or what. I'm not exactly sure how they get it into the trachea, but you still have to kind of intubate, right? But you're doing it with the feeding tube. It's a smaller tube, and you drip in the surfactant that way. There's also studies looking at aerolized surfactant, which I think is really what everybody would like to get to. So that might be something that we see in the future. And then there's also the potential of delivering surfactant through an LMA. Now, we don't use a lot of LMAs, mainly because most of our patients that need intubation are too small for an LMA, but innovation may be able to get a smaller LMA that would allow for this. So this may be something that we see. So pharmacologic agents used to treat existing BPD. We talked about the situation that often arises where we have a tiny baby who's between about 1 to 3 weeks of age, high ventilator support, high oxygen, and you may give those kids dexamethasone. So many of these kids that we think are high risk of developing BPD, or they're in that gray zone where they're not quite technically diagnosed with BPD, but they're sure headed that way. Some of these kids are going to get started on diuretics and bronchodilators. Diuretics we utilize to try to minimize the lung fluid that is in the interstitial space. We also use CPAP for that reason, and I showed a slide in the first half of the talk showing how descending pressure is felt to perhaps kind of squeeze out some of the water in the interstitium. So same concept behind diuretics, right? We're trying to, if there's lingering water in the interstitial space, we want to try to dry that out and decrease any diffusion space in the alveolar capillary membrane. Do you guys remember that as well? So we do use a lot of diuretics. We typically use aldactozides, probably our most common. We use Lasix as well. Lasix can be is a powerful diuretic, and I try to avoid using it chronically. What do I mean by chronically? I mean scheduled daily Lasix for days on end. Now, do we have patients that are on it? Yes. The problem, if you start Lasix really early and continue it ad nauseum, is that it can really weaken the bones. Now, we don't see this as much as I did when I was a fellow, but when I was a fellow, you could almost look at an x-ray and say, oh, that kid's been on, LASIK since the first week of life, because the bones would be very transparent-ish. They would kind of fade away, especially the ribs. And some of these kids would go on to develop spontaneous fractures. I had one family when I was a fellow, and the child was like a 23, 24 weeker, was super sick, had been on steroids and LASIKs, and the baby developed a spontaneous femur fracture. It looked like this on x-ray. And the parents were convinced that we abused their child. And it was a very sad case, but it was predominantly from poor nutrition, LASIKs, steroids, all these things we were trying to do to make the baby better, weaken the bones to such an extent that with a routine blood draw, somebody probably just put a little too much pressure, and then you have a fracture that looks like an X in the biggest bone in the body. So I try to avoid chronic LASIKs if I can. Bronchodilators, you may see these used more in our severe BPD kids that we've had of late, but in general I try to limit bronchodilators like albuterol to babies that appear to be having bronchospasm episodes. And then for those ones that we try, if they appear to respond, then I will say, okay, that makes sense to keep it going. Pharmacologic agents used to treat existing BPD. We use systemic steroids. We also use inhaled steroids. There's no obvious benefit, but some centers still use it, including the center that we've been consulting a lot, Nationwide Children's Hospital in Ohio State. So they use systemic steroids and inhaled steroids to treat babies with existing BPD. So the severe BPD patient, this is the type of patient that I think has caused us to have a lot of anxiety in our unit lately. Sometimes this severe BPD in the medical literature will be abbreviated a little s BPD. These are babies that require supplemental oxygen at 28 days and a need for greater than 30% oxygen at 36 weeks corrected age if the baby was born at less than 32. But there's different categories of BPD. There's mild, moderate, and severe. And I skipped the first two categories because this isn't a BPD talk, but I put the stuff in here because I know a lot of you want to hear about this. So anyways, to have severe BPD, you have to have very specific criteria, and essentially you need to be over 30% oxygen and requiring some support, some descending pressure at greater than 36 weeks of age. So that actually is only about 1% to 2% of all babies with BPD get categorized as severe BPD. So it's a very small number. Some people call these geriatric preemies. I don't know if you've heard that term, the geriatric preemie. So these are babies that are in the NICU well past their due date. When we take care of these babies, many of the ventilation strategies change dramatically from everything we've talked about in the prevention of BPD phase. So these babies have high lung resistance. They need really long time constants. They may take 4 to 5 seconds or longer to exhale. And so unlike the tiny babies where we're using high rates, low volumes, these kids need low rate, high volumes. Okay, so why do they need such high volumes? Well, again, going to back to the first talk, like I've said about 15 times now, we remember the alveolar ventilation equation. So tidal volume minus dead space times rate controls your alveolar ventilation. So if you decrease your ventilatory rate to really, really low, like 10 breaths a minute, you're going to have to go up on the tidal volume, right? The other variable in the equation to keep your minute ventilation or alveolar ventilation adequate. So these kids have to have low rates but really high tidal volumes. So their rates are going to be anywhere from 10 to 15 breaths per minute. And that's very contrary to what we're all used to seeing. And again, you have to have these high tidal volumes to allow for adequate minute ventilation. We try to avoid chronic sedation in these patients, which can be quite challenging. We have to be aware of possible tracheomalacia and pulmonary hypertension. So typically, these babies, at least when I'm on service, I try to do a screening echocardiogram once a month to screen for the development of pulmonary hypertension. So this is an example of an X-ray of a patient that could have severe BPD. And I think I showed this in the first half, but this is a baby who's hyperinflated. There's areas of these cysts that are overinflated, and then there's areas of patchy atelectasis. So this is the X-ray you don't want to have. So we talked about time constant in the first half of the talk. The time constant, there's an equation for this, resistance times compliance. We talked about one time constant is defined as the time necessary for alveolar pressure to reach 63% of the change in the airway pressure. So I think of the time constant as how long it takes for the breath volume to be equilibrated from trachea down to the alveoli. This is an article by lots of famous neonatologists about how to care for these babies. I think I had Cindy or Kim Graham or somebody send everyone these articles months ago. If you're really interested, I would recommend reading these. I think I just sent 2, and if you read both of them, you would probably have a pretty good idea of the strategies and philosophies of how to take care of these babies with severe BPD. It's not easy. It's just an idea of how different things can be on an X-ray and a CT. This is an X-ray. Look at this CT. Look how much more information it gives about how bad these cysts are. So some of these kids will get chest CTs. And I just want you to see how extensive these cysts are. They're everywhere. Sometimes they're hard to appreciate on a chest X-ray. So sometimes these kids have lung disease that is much worse than we're able to detect with our X-rays. So back to the time constant. So these kids need long eye times and lots of time to exhale. I don't want to belabor the time constant concept because we covered it already, but it's an important concept to be aware of, especially when you take care of these kids with severe BPD and you are asking the question, why do they need so much time to exhale and inhale? So this is the different categories of BPD. So let's just start with mild. So mild BPD, oxygen treatment at 28 days of age in a baby breathing room air at 36 weeks or discharged to home. So they required oxygen at 28 days, but they don't at 36 weeks. This is about a third of babies that are born with very, very low birth weights. So about a third of babies less than 1,500 grams. And these kids do really well. Death after discharge, only 1.5%. Moderate BPD, a baby requiring oxygen at 28 days who's receiving less than 30% oxygen at 36 weeks corrected age. So you can see these are very specific definitions. So this is about a third of the tiny babies with BPD. And yes, a slightly higher mortality. When we get to severe BPD, there's broken down into type 1 and type 2. So we had a patient that we transferred recently who is type 2. And just look, we're talking about a very small percentage of kids. So this would be a baby that required oxygen at 28 days who's still requiring mechanical ventilation at 36 weeks corrected age. So we had another patient who was sent home on nasal cannula oxygen who was in the type 1 category. So that patient was in room 36 when that patient went home. So again, that baby was a severe BPD baby, but type 1. So these are very, very rare cases, very sick patients. And you can see the risk of mortality is 2 to 3 times higher if you have severe BPD as opposed to moderate or mild. So when we've talked to the physicians at Ohio State who have what's widely considered to be probably one of the best, if not the best, BPD units on the planet, what they've told us is that with these severe BPD patients, we really have to accept that this is a chronic disease that is going to take months or longer for the babies to get better. And that's extraordinarily difficult for NICU people like myself to grasp because we want our patients to get better in hours or days. We're not used to thinking about a patient that needs chronic ICU care for months. So that's very challenging. But what they recommend is that we have to change our mindset and realize that the time frame is much, much different. They recommend not weaning the babies rapidly, weaning them slowly, along the way focusing on IV nutrition and developmental care. I mentioned we have to screen these babies for pulmonary hypertension, and the reason for that is that pulmonary hypertension can occur in anywhere from 30 to 45% of babies with moderate to severe BPD. So I do echoes once a month. The textbooks will often say, do one every 1 to 2 months. Sometimes if these kids have pulmonary hypertension, they may end up on inhaled nitric oxide or sildenafil. Sildenafil can be given orally. It does have some toxicities, but they're generally felt to be low. This severe BPD topic is one that probably warrants its own hour or 2-hour talk. So I just wanted to introduce some of those topics and data for you. I've asked a couple of my partners to consider writing a talk on this because I know lots of you have anxiety about these patients. And I'll stop there and answer questions, or try to answer questions.
Do you foresee us changing any of our current practices that we do with our preterm kiddos? I feel like sometimes there's mixed opinions between physicians on how it should be addressed, like assuming like whether we're intubating as complete or going to the NI, like using a rate versus going to CPAP, those sort of things. We're switching from that to invasive cannula sooner. There's been concerns about like eye maturity, you know, and FiO2s, but also how does that counteract with staying on ventilation at WP?
Yeah, I think you're going to see some variation from physician to physician. I don't think our variation is as extreme as many groups around the country, even though there's probably enough variation to drive many of you crazy. That's not our intention. I think within our cohort, we have relative being the key word, relatively similar philosophies and strategies. I don't foresee any major changes right now with the prevention of BPD ventilator strategies. You might see nuance within the strategies, but I don't think anything major. I don't know how soon this Lisa or Liza is going to infiltrate neonatology, but I think that's probably coming. I hope aerosolized surfactant just becomes available before it's necessary to do the Liza intervention, because I think that's where everyone really wants to get, is aerosolized surfactant. Mechanical ventilation with or invasive is never going to go away because people are pushing the envelope lower and lower. So even here we've resuscitated 22-weekers, and they've been doing it in Japan for decades. And those kids are just, some of them are going to need invasive mechanical ventilation because their chest wall is just so compliant they just can't stent their airways open. As far as the switching to low flow, I think most of us try to avoid going to low flow with 100% oxygen if the retina aren't mature. For most of our patients, I think that'll probably continue. But the thing about that, thing about ROP is, remember, hyperoxia is bad too. So ROP, the risk is increased with hypoxia and hyperoxia. So, both are bad. But I think we'll probably try to, in general, maintain the ability to wean your FiO2 when your retina are not mature. You might see occasional deviations from that. I don't know if I...
And we had a patient, or have a patient, I should say, that where we remained on CPAP on room air, and a lot of it is due to the gestational age of the kiddo, and obviously having the maturity, that sort of thing. But what I'm curious is, are we doing a disservice to that patient by leaving them on continuous pressure and not trailing them about it?
So 21% and I think that depends on the patient. If they're tachypnic and having a lot of alarms, then it may be wiser to keep them on CPAP. Now, how tachypnic, what's a lot of alarms? That's kind of a gray area. But there are many places around the country that if the baby's tachypnic, they'll just leave them on and let them grow.
I mean, I left and came back for a few years, but where I was at in between, like it was a standard protocol that you meet with our patients. If they were less than 32 weeks gestation, they stayed on CPAP until they were 32 weeks.
Yeah.
And So, but I'm like, but after like looking at some of this and talking about how ETs can still occur, even with non-invasive ventilation, it makes me wonder, are you creating more problems or, instigating more issues by leaving them on? I don't know.
Yeah. I think it depends on the baby, because not all 30 to 32 weekers are the same. Certainly, there are many places that if the baby's smaller and you're worried that they don't have enough chest wall rigidity to, keep their chest stented open. So you say you have a 32-weeker and they're only 1,200 grams, and they're a little bit tachypnic, then I just leave the baby on CPAP and let them grow, and that's probably fine. On the other hand, if you've got a 32, 33-weeker and they're 1,600 grams and they're not hardly having any tachypnea and they're not having a lot of alarms, they seem more mature with their control of breathing, it might be fine to try that kid in room air. So I'm sort of indifferent and try to let the babies guide me. I don't know if I've answered your question, but yeah, I mean, I don't know if that there's a hard, fast rule that, oh my gosh, this child is less than 1,500 grams. You have to keep them on CPAP until they're 1,500 grams or 32 weeks. But there are places that follow that. I guess I would say.
Is there lung tissue though by leaving them on the continuous pressure? That's my question.
You might if it's too high.
That's what I'm saying. Like, are we causing damage by leaving them on? Just because that keeps them on room air. Does that make sense? Like, where if we leave on a CPAP for 4 or 5 and they're on room air, but yet we could be causing them damage by having them sitting pressure in there consistently.
Yeah, I think it's probably a pretty low risk if they're on a 4 or 5 because your glottis, your vocal cords are going to give you a sitting pressure of 4 or 5 anyways. It's a really low support. If they're on 8 or 9, I would say no. You should wean them if they're not tachypnic and not have So I think you potentially could be imposing injury at a pressure of even 6, 7, 8. But if you're on 4 or 5, I probably wouldn't get too excited. Other thoughts?
I want to say something from a nursing perspective. I worked with a neonatologist a long time ago who was also a pulmonologist. And when he was doing his fellowship, he worked with a lot of people with COPD. And he was like, I just went, they're all real crabby. They were just not happy. He's like, why are they so crabby? So he decided to inhale pure CO2 to artificially increase his own CO2. And I'll never forget, he said, I feel like shit. I mean, he did not feel good to have CO2 elevated like that. So for every patient I ever took care of like that, yeah, they did feel like crap most of the time. I mean, it was so much work just to breathe. And my goal every day was just to find some happiness for that baby, some comfort level, some pleasure in their life, whether it was sucking on their pacifier or being held. Because sometimes for those kids, that's the only thing, that's the best you can do for the day. And that's so different from taking care of our other patients. We assume that they feel good after we do all the things that we do for them, suction, and change their diaper and everything. They look like they feel good. These kids, they look like they're tired, every day. And it's a different level of nursing.
Yeah, that's a really good point, and that's the burden of that is really on the nursing staff. So you guys might not want to hear it, but it's really important for you guys to have consistent caregivers for these babies because I walk in there, I'm in there for 3 minutes, maybe 5 or 10. So I don't know the babies like the nurses or the RTs do. I just don't. So I don't know if you have your own kids or even your own dog, you get a vibe. These things you can almost feel, and a lot of nurses can have that with the patients where they are like, yeah, something's not right, and also how to comfort them, and the parents too. A lot of times will tell you, so you have to listen to the parents. But to me, that's where consistent caregiving, trying to learn as much as you can about developmental care. And, I can read about it, but I'm not the one doing it. So the burden is really on you as the nursing staff to become excellent at developmental care and doing your best to be consistent, have consistent caregivers that learn the patients. Because you're right, keeping them comfortable is a big part of it. And you don't want to use drugs if you don't have to keep these kids happy. But you've all seen it, like a kid who's having a restless day and his FiO2 is up 10 to 15%, and then I see it all the time. And then a different nurse comes on at shift change who maybe knows the baby better or has some nuance in her head that this is what he needs or she needs, and they do something, and the baby's FiO2 is down by 15 to 20%. The kid's breathing more comfortably, and we didn't give a drug. And I'm like, what happened? Oh, well, I don't know. I just did this. And you're like, okay, well, we should always do that. But then the nurse goes off shift, and and it doesn't happen. I don't know how to fix those things, but how it is that a nurse knows to do those little things is amazing to me. So I don't know how to do that stuff. Other thoughts?